Thank you so much, Jeff. And thank you to the organizers of the function for allowing me to share the insights on the management of diabetes in the modern day. The phone. I just wanted to make a few disclosures, because when we stand here or when we speak in forums like this, we have to announce that we have received some sort of financial support, but everything that I'm going to be saying here is not of Servier's mind, it is my mind. So whatever mistakes I make, don't blame Servier, blame me. I'm not going to be very long because the slides are quite hectic, and I'm going to allow them to speak more than I will, just so that I can allow the appetite to be stimulated. Whatever else is missing from this presentation, you will get from the slides, because we can email them to anyone who is interested in receiving them. And now let me get straight to the point. The whole point about this meeting tonight is to talk about the essentials of modern day management of diabetes. It has been divided into 5 sections, and each section is addressing a specific point that is to take home as we go further in the management of diabetes. But the question is, why are we interested in the management of diabetes today? And the reason is we are going to see a lot of burden from diabetes specifically and the complications thereof. Following this pandemic from 2019 till about 2045, this is now the era that most of us are going to be practicing in. We're going to have to prepare ourselves for a relative disaster. If it was a pandemic of COVID before, we're going to see a pandemic of diabetes now. Unfortunately, diabetes is a more chronic pandemic than COVID. And 1 in 10 adults, 1 in 11 adults, about 10% of our adult population will be suffering from diabetes. And the numbers are going higher and higher by the day. At least 1 in 2, some studies cite 1 in 3 adults with diabetes are undiagnosed. So for every diabetic that we see in our practice, there's an undiagnosed one running around without being diagnosed. So that puts the number worldwide to a total of about 232 million people that are walking around undiagnosed with diabetes. And the numbers are going up by the moment. In South Africa alone, diabetes is the second leading cause of death. Of note is that for females, it looks like it's killing us more than it's killing males, because males are killed more by TB from what we have here. And females are the ones who are leading in the deaths of diabetes. And again, when you're looking at South African reports or statistics, it looks like diabetes is ravaging us from the time of diagnosis to the time where we are having pre-diabetes, or what they used to call pre-diabetes or IGT, as well as mortality due to diabetes between the ages of 20 to around 18. So it looks like we're gonna have to gear ourselves and know how to be comfortable in managing diabetes in going forward. I know we know all about the complications of diabetes, so I'm not going to sit much on that, but we know that diabetes does give rise to both micro and macrovascular complications. But of significance here is that self-management for people with diabetes is an important, if not the important part of successfully preventing or delaying diabetes complications. So when you're talking self-management, you're talking that our patients have the responsibility to manage themselves. The 15 to 30 minute slot that we have them in our practices is not enough. They need to be trained. They need to go to a mini medical school the time they see us, so that by the time they walk out of our practices, they know how to take care of themselves. There must be their own dietitians, their own nurses to monitor their sugar levels. There must be their own physicians in terms of how they control or adjust their treatments if need be, but they also need to understand the pathology that they are contending against. Again, the magnitude of complications from diabetes is quite high. 50 to 80% of people with diabetes, they die from cardiovascular diseases. A lot more of those die from lower limb amputations, or they suffer from lower limb amputations. About 45%, they suffer from kidney failure. 30% with retinopathy, and about 20% with who are going to die with stroke or stroke-related complications. Suffice it to say that most of the modifiable conditions or risk factors that we're confronted by are usually undealt with. Our patients do not want to lose weight, or they fail to lose weight for whatever the reason. Our diets still haven't changed, even though there's so much talk about diets, new diets, and the diet fads that we're confronted by. Cholesterol remains one of the leading causes that contribute to the risk factors. And I'm not going to talk about smoking, even though it's written in the package, smoking is dangerous and is harmful to the health. We are not exercising as well as or as much as we should as patients, and dare I say, as physicians. So the burden of diabetes is not going to affect only our patients, but it's also going to affect us as clinicians if we're not careful to handle the risk factors, especially those that we can modify. We can do nothing much about the unmodifiable or the non-modifiable risk factors, except to control what we can and to make sure that we can actually reduce the stigma of diabetes within our bodies. This section here is talking about the importance of A1C, why it is important to control it, and why is the A1C such an important tool when we're managing our diabetes patients. Upfront, they've noticed that a reduction of the A1C, at least by 1%, just 1% reduction of A1C, can result in a decrease or in an improvement in the microvascular and macrovascular complications as well as death. So when you're talking morbidity and mortality from diabetes, reducing the A1C just by 1% can result in major benefits to our patients. But the thing is not about just reducing the A1C, it is about early reduction of the A1C. Most of our patients come and see us. By the time they see us, they've had diabetes for quite a number of years, at least 5 years, without them knowing it. And a diagnosis, 50% of those already have complications, whether they are macro or microvascular. And up to 50% of their beta cell function has already been lost by the time they come to see us. That needs to be changed. That is one of the targets that we need to change. We need to find them earlier, and we need to find them before they mount complications from the diabetes. The only reason being to preserve beta cell function and to delay the complications as well as death. So the need for early aggressive therapy to slow or prevent beta cell failure becomes pertinent in our setup. Poor control in diabetes, results obviously in chronic hypoglycemia, which leads to long-term implications. I'm not going to belabor that. So again, the emphasis of this slide, of this section specifically, is on glycemic control. We know that with the best care that we have, glycemic control will deteriorate over time. And this is because of the natural history of the condition. So with conventional medication, with glibenclamide, metformin, and insulin, our patients will progressively get worse. No matter how hard they try to exercise and diet, the nature of the disease is that it takes a downward course. So our responsibility is to monitor and aggressively control the diabetes as soon as we get to know about their status. Most of our patients are on polypharmacy to a point that now we have the benefit of even giving them triple oral therapy before we can embark on insulin. So the most important thing about early control is that there is a good legacy effect when you control the A1C much early in the disease. The study that was done by Holman and them shows that if you control the diabetes at the time of diagnosis and you keep it less than 6.5, 6.8% by the time they're diagnosed, if you can control that diabetes within a year of diagnosis, that benefits them much later, even if there may be loss of control later on. So if you take patients, they took patients, started them on treatment, conventional treatment, and some on intensive treatment. And they looked at the benefits of having been controlled much earlier than when we control them later on. And I think the reason is clear. If you control them much earlier, atherosclerosis will not mount as well as it can if it's left until too late. So there was a reduction in microvascular complications, a reduction in myocardial infarcts and all-cause mortality in patients who are controlled within the first year of diagnosis than patients who are left uncontrolled for a year or two, and then we control them later on. So when we meet them, say 3 years later, all of them 3 years later, the A1C for A1C, even if they have the same A1Cs 3 years later on, the most important part is the fact that they were controlled at 1 year. If they were controlled at 1 year, they benefit from that control, which is a good legacy effect. The opposite is also true. The bad legacy effects of hyperglycemia is what catches up with them. And that is what we need to pursue aggressively and change. So the durability of A1C in advance, and we know that in advance they used gliclazide. They compared standard treatment and they compared intensive treatment based on gliclazide MR. And you see here that the mean A1C at final visit was better with the gliclazide. I'm going to come back to this slide later on, or to something similar, but suffice it to say, we need to hit hard, and we need to hit hard early. If you can manage to bring those patients to a good legacy, it looks like the body remembers what our A1Cs were at the time we were diagnosed, or shortly within the year of our diagnosis. The body remembers, and that benefits our patients favorably. And I know that that's a far cry from how our practices are run. I know from my own patients, they come in very late, they come in with complications by the time I see them, and we lose out on the benefits of the good legacy effects. It is real, this legacy effect in the management of controlling type 2 diabetes and the mortality. So I'm not going to belabor this, but suffice it to say that patients, they were stratified in different A1Cs, and we could see the ones that had a good control earlier on, HbA1c of less than 6.7, between 6.5 to 7, they fared better much later on, even if they were to lose control later on. That I have to say over and over again, because it becomes pertinent. It becomes, I cannot overemphasize that it becomes necessary for our patients to be controlled, especially when they're still at the moment of being scared of diabetes. The minute they become used to it, if they were scared enough in the beginning to control their sugars, that's going to benefit them later on to some degree. Maybe not, it's not going to abolish the effects totally, but at least it does give them a benefit. Now, poor glycemic control in the first year leads to increased risk of micro and macrovascular events as well as death. I'm going to just go through the slide briefly because I don't want to, I mean, it emphasizes what we are talking about, the good legacy effects and the bad legacy effects of hyperglycemia. So the most important thing is to risk stratify our patients. What are we aiming to achieve with them? What kind of A1C do we think each and every one of our patients deserves to have, or are they able to meet? So when you're looking at a person who is at a low risk of hypoglycemia, who has got newly diagnosed diabetes, his life expectancy is long. We're talking about a relatively younger person here who does not have complications like kidney failure, who's likely to get hypoglycemia with medication, who does not have comorbidities, especially the major ones. We're talking about a patient here who's got a healthy attitude, who's highly motivated, and so forth. That patient, we can aim for an A1C of 6.5 and less. So I know that traditionally we've always spoken about 7, but now if you want to be aggressive, especially in the person who's highly motivated, aim for an A1C that is much lower than 7. Most of our patients belong to around the 7 population group. That is, the risk is somewhere in between low or high for hypoglycemia. They have had disease for quite some time, but maybe not too long. Their life expectancy is not that great, but they're not dismal, or they're not towards the end of their life. They have some comorbidities, and they have some established macrovascular disease. Their attitude is in between. They're motivated, but they're not so highly motivated. Then there you can aim for 7. But the older patient who's got more complications, who has had diabetes for a long time, the idea there is not to control them, like to be so strict and harsh with their control. The attitude is to make sure that they don't become so hyperglycemic to warrant admission and have frequent other complications. So the whole point about this slide here is that 7 is not the gold standard, because normal A1C is less than 6 anyway. The idea is to get them to as low as possible without experiencing hypoglycemia. So A1C is generally recommended by international guidelines, including the WHO as well as the International Diabetes Federation. So 7 is usually the gold standard that we always aim for. But the most important thing is that you must look at your patient and manage them as individuals. Now, for the SEMSA guidelines, like I said earlier on, this is just again to emphasize, younger patient, newly diagnosed, no comorbidity, long life expectancy, less than 6.5. The majority of the patients must be in between. But patients who are older with comorbidities, renal failure, and so forth, we can allow them the flexibility. But all our patients should never be found with an A1C of 8.6. All our patients should have an A1C less than 8.5. That is what this is in summary, this is what it means. So any person who comes with an A1C of 9 that we need to be alert about. So the summary is, there's a rising prevalence of type 2 diabetes. I think COVID has contributed a lot to that. And COVID, by virtue of the spike protein, and dare I say, we're probably going to see more from the vaccine because it also carries the spike protein. So there's a rising prevalence of type 2 diabetes. There's also other potential additional factors to that. The goal of our type 2 patient treatment is to control glycemia and reduce complications, which we are also familiar with. And achieving A1C control early and safely and in the long term is important in managing our patients. The legacy effect. SAMHSA guidelines, again, less than 7 for the majority of patients, but everyone less than 8.5. That is the main take home for the slide or for this section. The problem that we are confronted about is therapeutic inertia. We may sit here and we may all understand the need for early aggressive management and for early upscaling the management, but there is this tendency amongst us clinicians and amongst the patients as well to not want to upscale our management. So therapeutic inertia is failure to advance therapy or to intensify therapy when it is appropriate to do so. So you may see a young person recently diagnosed who's not at risk of any hypoglycemia, no comorbidities, but still sitting with an A1C of 7 and still say, go home, faithful servant, continue with your treatment. And yet we know we're supposed to aggressively bring it down. So this is what we need to override in the era that we are coming into, the era of COVID, the post-COVID era. We need to override our therapeutic inertia, and we need to make our patients come on board so that they can also appreciate the need for early aggressive management and for ongoing support and control. So the main clinical hurdles, I think for me, the one that I meet, and I know I'm talking for everyone else, is this name called insulin. When we mention insulin to our patients, it's like the grave, it's like we're digging a grave for them. And this is one obstacle that we need to overcome as clinicians. Our patients need to believe that they are lacking insulin. They're not lacking metformin. The deficiency in their bodies is not metformin. They're not lacking DPP4 or whatever. They are lacking insulin. So they need to be primed much earlier in the diagnosis or in the treatment spectrum, even before they need insulin, that at some point we're going to have to kick in and use insulin. So yes, it's good enough to diet and exercise. We don't stop that. Monotherapy, combination therapy, you can even go to triple therapy now, oral medication, but we have to come to a point where we're going to use insulin and the GLP-1 receptor agonists earlier on in the disease management. I'm not going to go through that slide. It just shows us how long it takes for us to finally come to the party of using insulin in our patients. In Africa, it looks like the mean age of the patients that we are treating when we start insulin is usually around the age of 55. And it's patients who have got a mean A1C of 8.6, that is mean, meaning that some have got a higher A1C than 8.6. So we leave it until it's too late, but we're not alone in this. This is a worldwide problem. Doctors generally everywhere and their patients are resistant to initiating insulin early or to increase the treatment aggressively. So this is, for me, what we need to change much more than anything, especially if we're going to be contending with. What we need to remember is that diabetes doesn't only cause macro and microvascular complications, it also causes liver failure if a person has got steatohepatitis. It also puts patients at risk of getting cancers and many other complications, infections. So we're not only looking at macro and microvascular complications, we're talking the patient overall. So when we want to manage our patients, we're not just managing the condition, we are managing everything else that comes with it. I don't know how many patients are sitting in hospital with complications of diabetes alone. It gets to a point where it's going to become really a burden, not just to the hospitals, but also to the medical insurance, to the insurers, those favorite people that we work with. I don't want to say at this point that the major hurdle amongst us doctors, I think, is the fundability of the treatments. It's well and good to be talking about all these lovely molecules, but at the end of the day, are they accessible? Are our patients able to receive them? Because no patient wants to pay a cent after they've contributed to the medical insurance. Consequences of inertia, again, same old, retinopathy, diabetic retinopathy, as well as nephropathy, as well as other complications. So when we don't treat our patients early and aggressively enough, we are faced with all of this. I'm so sorry about these slides because they are cut off at the top. It would have been better if they were cut off at the bottom, but we're going to make this available to everyone at the end. Now, when we are looking at the complications, the cardiovascular complications of diabetes, patients with A1Cs that are greater than 7% and not receiving intensive treatment within a year, again, it's belaboring the same point, compared to patients who have got an A1C that is less than 7%, who received the intensive treatment before 1 year of diagnosis. So all diagnosed in 2022, we treat them aggressively. They reach their targets to less than 7 at least, and some don't. Those that reach their target of less than 7% within that year of diagnosis, they will definitely fare better much later in their disease spectrum. Again, this is for emphasis. So I'm not going to go through that slide, but it just looks at the reason why our patients are not being initiated on the intensive management. What are the barriers? So the barriers can range from what the patient is doing or what the doctor is not doing. So most of our patients are not appropriately educated on insulin. I'm talking about patients who are on insulin. When you sit down with them and you ask them to titrate their insulins, they are far from getting or grasping how to do it properly. They chop and change whenever they are ready. They increase the dose at the time that they're checking the sugar. And yet that dose is a reflection, that level is a reflection of a previous dose. But then they wake up in the morning, see a reading there of 13, they increase the morning dose, and yet that 13 is a reflection of the evening dose. So they are not educated as to exactly how to manage their diabetes. Patients' perceptions of insulin. My mother took insulin and then she became sick. She had renal failure immediately after taking the insulin, so I don't want to take insulin. My relative or my neighbor took insulin and then they died shortly thereafter. So insulin is dangerous. I don't want insulin. The fear of hypoglycemia, impaired quality of life when one is using insulin. No, I started using insulin. I became blind shortly thereafter, so insulin can cause blindness. These are all the stereotypes that we get to hear from our patients. And it looks like that textbook of medicine is much more received. It's much more well received than the textbook that we try to confer to our patients, and that needs to change. I do not know how Servier and the likes are going to get into that space, because that is the space where I really feel it's one thing to educate doctors, but more of the education needs to go there to the communities, especially when it comes to diabetes and so forth. The pain of my heart is the resource issue. The patients we are sitting with, we see all these fancy molecules that are coming out now. They are so brilliant. They work like a charm. But then when you come and you write that script, it goes to the medical aid and it's rejected. Motivation letter after another, the patient still doesn't get, the benefits of using the medication that we know is available. So we are seeing now that the management, even of diabetes, is becoming polarized. There are some who can benefit and those that cannot. So the rich can benefit, but the poorer can't. So the minute you see a medical aid, the medical aids, that your patient is not going to ever be managed properly. And I do not know how that needs to change, but that needs to change, if indeed we want to give our patients the best care that they deserve. So sorry that the summary doesn't project very well in the screen, but the summary here is that diabetes is a progressive disease. Therapy must be started early in the natural history of the type 2 diabetes to prevent progressive beta cell failure. Early tight glycemic control is associated with reduced microvascular and microvascular complications. That is the legacy effect. The effective treatment of type 2 diabetes requires multiple treatments used in combination to address the multiple pathophysiological defects. I'm sorry about this. And that therapeutic inertia and adherence are the key reasons for the efficacy to effectiveness.
Would you like me to change the color of the font?
A gap of the real world setting is fine.
I'm going to post it in the chat, but we will make the slides available.
Yeah.
It's like a lighter color.
I don't know why it came out like this, because
Light gray, I think.
Okay. Now in section 3, the effects, what we want to look at is what are the effects of the newer anti-diabetic treatments. And effectively here, we're going to need to just take a walk down memory lane. They start here, this slide, it starts showing the history of insulin from 1950, but we know that insulin has been with us for about 100 years. In fact, since January 1922, that is when insulin was discovered and was used in our patients. Ever since that time, the pathogenesis of diabetes has been better elucidated and molecules have been employed to try and address the different effects of the problems that we meet in diabetes. So sulfonylureas were first used in the UK much earlier, around the 50s, like 70 years ago. Metformin has been used again around 60, 70 years ago. Then we went to insulins to a point where we started using insulin that was modified. We are now talking many other classes. I mean, we're talking SGLT2s now. We're talking about GLP-1 agonists, receptor agonists. We're talking a lot more newer molecules, and all of them are addressing some spectrum in the pathogenic processes of diabetes. Long and the short of it is that the management of diabetes has evolved with time. We're getting these novel molecules which can work like a charm, certainly not without their side effects. As a result, when you're looking at the SGLT2 inhibitors, that is the sodium glucose co-transporter 2 receptor inhibitors, when you're looking at the cardiovascular outcome trials, these drugs are effective in the management of diabetes. They don't have class effects. So you need to know which one we are employing for a specific patient. For an example, when we started off, there was a clinical trial, Credence, that was done some time back. And the molecule was promising. They used canagliflozin. The molecule was promising, but it turned out that somewhere down the line, there was a higher risk of amputations of the lower limbs with the same molecule that is trying to prevent the complications of diabetes and so forth. But the long and the short of it is that the outcomes looking at the cardiovascular effects of the medications, when you're talking empagliflozin, comparing it with cana, as well as DAPA, these are the ones that we have. I don't think canagliflozin is still used in South Africa. We're using mainly EMPA and DAPA gliflozin. When you're looking at these molecules, they are good, they're beneficial, especially when it comes to heart failure patients. We use them a lot because they also, with their reduction of glucose absorption, they result in more glucose being excreted, and then the water follows that. So they also have a dehydrating effect, which benefits patients who have got heart failure. So when you're looking at these that are available now this is looking at practically almost all of them. When you're talking LIDA, you're talking liraglutide, that is GLP-1. When you're talking sustain, you're talking semaglutide, that is a gliptin. Sorry, semaglutide. Semaglutide is a DPP4. When you're talking abiglutide, dulaglutide, and all of these are clinical trials that are showing us the cardiovascular outcomes of the latest molecules. Now, when you're looking at their effects, like I'm saying, they are not all class specific. Cana was not as beneficial as dapagliflozin. So when you're looking at dapagliflozin, you find that the benefits far outweigh the risks of the side effects. As a class, the SGLT2 inhibitors, they can cause pancreatic disease. Some of them, they are known to cause pancreatic disease. Some of them can cause bladder cell tumors, or they've been known to also contribute in osteoporosis or bone fractures. So as a class, now you need to choose the ones that are relatively safe so that you can prevent some of the negative outcomes. They are all available, more or less similarly priced, but you need to be sure of what you are using at what point you are using it. Now, when you're talking about cardiovascular effects of the GLP-1, sorry about this. When you're talking about the GLP-1 effects, for an example, the GLP-1 agonists, they are going to come up. I think the future of management of diabetes is going to circulate around the GLP-1s because they are metabolically neutral. They don't cause, in fact, most of them cause weight loss, which is ideal in the management of diabetes, as opposed to insulin, which can contribute to weight gain. Some of them are long-acting, others are short-acting. So it becomes beneficial when you're looking at a short-acting GLP-1 inhibitor, agonist, that they usually take care of the postprandial levels of sugar, as opposed to the long-acting ones, which take care of the preprandial. So the combination in the future probably is going to be a short-acting, like a short-acting insulin with a long-acting insulin. I think that is where the future is going, but obviously I am not the authority in this, but it looks like that may be the way to go. So when you're talking liraglutide, you're talking about a short-acting GLP-1 agonist. And when you're talking about what is this drug?
Dulaglutide.
You're talking about a long-acting GLP-1 agonist. Dulaglutide is Trulicity. And then Trulicity. Dulaglutide is Trulicity. Okay. From Sanofi, it's from Sanofi most.
Yeah.
Mm. Mm. So, yes. So you're talking about the long acting and the short acting. So exenatide. So exenatide is a short acting one, liraglutide are short acting, and then we get the longer acting ones. So we need now to understand what we are employing when we're employing them. And the most important factor being that they cause weight loss. And that is ideal. Even though liraglutide is not registered for weight loss, Saxenda, which is also a liraglutide molecule, higher doses, it is registered for weight loss. So we are looking at these newer molecules that are beneficial also in the complications of diabetes and so forth. So it's going to become a very interesting stage when we're looking at what we can do, especially if we can get hold of what we can use. Okay, liraglutide, semaglutide. Semaglutide is Ozempic. No, Ozempic, yes, it's Ozempic. Which company makes it?
Same company, Novo. Which one? Novo makes.
Ozempic is Novo. Ozempic is Novo. You yes, Novo. So when you're looking at them, it's liraglutide is short acting. Sema is long acting.
Yeah.
Same thing. So liraglutide made by the same company. The other one is short acting. The other one is long acting. We are seeing that there's the reduction of CV death, non-fatal MIs and non-fatal strokes with both of them. So in the long term, this is what I mean when I'm saying that we may have to look at reducing, giving them as a basal bolus of sorts. Not that it's ever going to be used like that, but it may come to that point where we're using a combination of the two, the long and the short acting, like we're using short acting insulin or rapid acting insulin and the long acting insulin. And then when you're looking at the characteristics of the populations enrolled, most of the patients that have been enrolled in these clinical trials are patients who do not have severe disease, severe coronary artery disease, severe strokes, and because those are exclusions by and large. So we do not have the benefit of knowing exactly how these drugs behave in those population groups. But for those that have included patients who have had coronary artery disease, strokes, and so forth, there is benefit for all of these drugs. For patients who have had some disease process going on, but they usually are not effective as primary prevention measures. They're usually better as secondary prevention measures. So they will be beneficial in patients who have had a prior stroke or prior MI or prior revascularization and so forth. But they do not really show or confirm much more benefit in patients who have not had a prior condition, which is interesting in itself. So which patients benefit from these cardiovascular outcome trials? Looking at SGLT2s and GLP-1 receptor agonists, the cardiovascular outcome trials conducted on this, comparing it to the standard of care. So you're looking at Elixir, Leader, semaglutide, Sustain, Excel, that is exenatide. Exenatide is Byetta, ne? But I want us to have an idea, because sometimes we mention these names and we cannot put the word next to the drug, but I think it's Byetta. Sorry if I'm using the wrong names for this presentation. Yes, because sometimes we don't want to mention companies and stuff because we want to be proper, but that's what we do in our practices. So lixisenatide, that is your lixisenatide.
Keeping you on my toes yet.
Liraglutide is Victoza, semaglutide is Ozempic, exenatide is Byetta. We don't have this one, Soliqua. We don't have albiglutide. Dulaglutide is the Trulicity. So it's comparing practically the standard of care using all these SGLT2s as well as the GLP-1 receptor agonists. And the cardiovascular benefits have been seen and have been demonstrated in those cases. I'm going to go through this quickly because I do not want to belabor the fact. The greatest amount of efficacy that we have seen was seen with the Excel study, that is exenatide, 47% reduction of all the cardiovascular outcomes in real world in the American population. And only a minority of the type 2 diabetic patients are eligible for cardiovascular outcomes. Like I said earlier, we don't have a lot of our patients who have been exposed to some complication. And only about 20% of our patients who have been tested are giving us the results that we're talking about. But the bulk majority of them have not been used for the efficacy of these medications in the setup. Suffice it to say that the patients with established CVK and CKD, 15 to 25 of the diabetic population, we have seen that there is adequate, the goal of treatment is adequate glucose control, management of cardiovascular risk factors, and prevention of secondary events. I know this sounds redundant, but that is the main message of this whole thing. When we're treating our patients, that is what we're aiming to achieve. So the compelling indications for specific classes of treatments. So when you're looking at the specific medication, you want a drug that has been proven to reduce atherosclerotic cardiovascular disease, diabetic kidney disease, and heart failure. That drug must contribute in some way or another. If it does not contribute, at least it must protect. For an example, some drugs can be used in kidney failure, but they may not necessarily confer renal protection. Or some drugs must protect the kidneys, but at the same time, they must be used in all spectrum or at all levels of kidney failure for us to be comfortable with them. But then it's not always the case, because some drugs cannot be used at the end stage kidney failure spectrum. They can only be used, say, to up to stage 3 or stage 4 chronic kidney disease. So in summary, SGLT2 inhibitors, as well as the GLP-1 agonists, is only studied in patients with established cardiovascular disease. That is, it has been well elucidated in those patients. There is no MACE benefits, that is no major adverse events, that is from the cardiovascular effects in the subgroups without established cardiovascular disease. That is, they've been beneficial more in patients who need secondary prevention, more than they have been beneficial for patients or have been studied in patients who need primary prevention. So even though we know that logically, if you employ medication, it should reduce the implications and the complications. Most of these studies or most of these drugs have not been shown without any doubt that they do reduce they're beneficial in primary prevention of these conditions or these clinical complications. However, the SGLT2s do reduce hospitalization for heart failure in patients who have got heart failure with reduced ejection fraction. Oh my word. So all these abbreviations, we're gonna have to familiarize ourselves with them. So the SGLT2s reduce heart failure and hospitalization for heart failure in patients with heart failure and reduced ejection fraction. That is why most of our patients who go to see the cardiologist, they will come in with an SGLT2 inhibitor as part of the treatment for the diabetes because of the heart failure. So they are used not necessarily as an anti-failure treatment at this point. They're not registered for anti-failure, even though maybe eventually they may also be used for that purpose. The benefits in patients with cardiovascular disease were seen on the background of metformin, sulfonylurea, and insulin. So they are not, it's not like we only use these molecules, we use them in addition to standard care. And there's no evidence of additional compelling benefits for the general type 2 population without established cardiovascular disease. So we don't know if the benefits of the SGLT2s, if a person has not had any heart failure, we don't know how beneficial that would be in the management. So what are the primary versus secondary prevention effects? Are there any differences? So if you're looking at the treatments that we have been employing in the past, you know how we have used aspirin for all our patients, primary or secondary. There's no benefit in primary prevention of using aspirin. They're beneficial in secondary prevention. So if you've had a stroke already or kidney failure or whatever, that is where you should be using our aspirin. But by and large, we use aspirin for all our patients, even though they may not have had a prior event. So it's time to reevaluate. Patients who have had a percutaneous coronary treatment versus medical therapy, no benefit for primary prevention of complications. Intensive glucose control, using all the available management processes, is beneficial in primary prevention, maybe not so in secondary prevention. ACE inhibitors for prevention of diabetic kidney disease, no benefit. Secondary prevention in a person who already has some degree of a diabetic kidney disease, they're useful. SGLT2 for the CV events, primary prevention, no, but they are good in patients who have established cardiovascular disease. I hope that's clear. So when we're looking at, for me, what sticks out the most is the use of aspirin, the use of ACE inhibitors, especially because that is what we normally tend to put our patients on as a blanket. We tend to cover them all to say, okay, fine, you have diabetes, then you must be compelled to be on an ACE inhibitor. It doesn't work for primary prevention, but for secondary prevention, of course. This is now the second of the last sections before I go home. What about the remainder of the 80% of type 2 diabetic patients? Because we're talking about here, most of the treatments that we're talking about are for the use to the 20% that have been studied effectively, but 80% of our patients don't have the cardiovascular complications when we see them in our practices. What about them? Again, this talks about the ADA and the SAMHSA guidelines. For patients without established atherosclerotic cardiovascular disease or indicators of ASCVD or heart failure or CKD, the choice of a second agent to add to metformin is not yet guided by empiric evidence. So you cannot say without a shadow of doubt that if a person fails on metformin alone, I have to use this drug as a compelling indication. You cannot say that the next drug I must use, therefore, is this one, because there is no evidence for primary prevention. But if a person has had coronary artery disease or kidney disease, then we have a compelling indication. But for a person who does not have any other complications, the choice is yours. It must be guided by your clinical outcomes, by the way that you see your patient, the clinical presentation of the patient, other comorbidities or other complications the patient is faced with. So the drug of choice is based on the efficacy of that treatment or on the side effects of that medication, the costs, and the patient preferences. For an example, DPP4 inhibitors, or say, for an example, sulfonylureas may be preferred by the patients because they are oral agents as opposed to injectables. So you sit with your patient and you can play around with all the treatment options that are available over and above metformin. So for primary prevention, type 2 diabetics without established heart disease, that is the bulk of our patients. The main clinical objectives for risk factor management is to get the A1C down quickly and safely, employing whatever agent you feel will benefit the patient. The most important thing you are viewing to try and prevent macro and microvascular complications, not from the drug itself, but from the control of the diabetes. Because like I'm saying, there's no drug that has been proven to be effective in primary prevention. You also want to control the blood pressure. You want to control all the other modifiable risk factors that you can. So cholesterol, smoking, and so forth. The benefits of adding the SGLT2 inhibitors. So now we're looking at the different classes. So do we add metformin to an SGLT inhibitor? Do you add it to a GLP-1 receptor agonist? Do you add it to whatever other drugs? Now, if you're looking at the SGLT2 inhibitors, the benefit is that it's going to improve the glycemia. The amazing thing is that the SGLT2 inhibitors, they reduce the A1C by about 0.7%, which is quite moderate. I mean, that's mild. Our patients are sitting with HbA1Cs that are much higher than that. They employ an insulin-independent mechanism of action. So the risk of hypoglycemia is low with the SGLT2s. There's also the benefit of weight loss, improved blood pressure, and heart failure for some. And also they are known to decrease the triglycerides. But of benefit to our patients is that it's also taken orally. So our patients would rather go to this than to other medications. The adverse effects, on the other hand, like I said earlier on, they have been shown to cause quite a number of side effects, which we need to know specifically which of those SGLT2s would cause them. But generally, as a class, they cause mycotic infections, genital infections, fungal infections, because of the nature of the mechanism of action. The more glucose you have out of the urine, glycosuria, the more likely one is going to have urinary tract infections and genital infections of the genital, Polyuria, for obvious reasons, volume depletion, hypotension, and dizziness, especially those that don't have heart failure. The offsetting part is that they can also increase the LDL levels as well as creatinine because of the dehydrating component. Very rare, but also seen is euglycemic DKA. So patients will come in with normal glucose, but will be suffering from DKA. It has happened in some of our patients. Increased rate of lower limb extremity or extremity amputations, especially with canagliflozin, and then Fournier's gangrene, as well as the risk of bone fractures, And this has been thought to be due to the effects of the mechanism of action on vitamin D in the process of exchanging. Long-term effects, bladder cancer risk is also a possibility. Now, I don't know how you're going to say to your patient, I'm going to try this medication to you. In the long term, it may give you bladder cancer. It may also increase your bone fracture risk, but it's going to work fine for your heart. This is the risk and the benefit we need to measure. I'm going to skip that slide, but the benefits of using GLP-1 receptor agonists, they lower the A1C quite significantly. Obviously, they differ from one to another, with semaglutide being the best, or being the one that has got the best A1C lowering efficacy. Weight loss being very lucrative in the class, especially with Ozempic. Long-acting GLP-1 are better at reducing the A1Cs than the short-acting ones. And then the short-acting ones are better at reducing postprandial glycemia. They are the preferred first injectable versus basal insulin. So it looks like we're moving away now from our traditional basal insulins, and we're going to be starting looking at these ones as the option of choice because of the other benefits that they're conferring. I have 10 minutes left. And if patients are already on the basal insulin, then the GLP-1s are the ones that are preferred to be changed to. If you can manage maybe to switch our patients, especially those that can afford it or patients who are more motivated, then this is an option that we need to start looking at. Okay, I'm gonna skip this one. These are the remaining ones, but Trulicity or dulaglutide, it reduces the adverse events in the heart in older patients with multiple risk factors. So if you have an older patient who has got multiple risk factors and so forth, it may be a good option to consider initially. And coming to almost the end of the presentation, the side effects we all know, especially with the short-acting ones, because they decrease the gastric emptying, they may cause nausea and vomiting. It's an injection, it's an injectable form, so that you're not really running away from insulin, but patients may like it because it causes weight loss. It's fashionable to lose weight without much effort. But unfortunately, it's expensive, may be causing pancreatitis, risk of thyroid medullary cancers, as well as gallbladder disease. We need to warn our patients, especially for the worsening of retinopathy, because that becomes a significant side effect. So we talked about the GLP-1s and the SGLT2s. What is the benefit of adding DPP-4s to metformin as a second drug? Advantages are that they don't cause hypoglycemia. They're weight neutral, once a day, oral, and so forth. But then the disadvantages are listed there. I do not like the heart failure that we can get with Saxa and Vildaglipin. That is now Galvus, as well as Saxa is Vildagliptin is Galvus. Saxagliptin is yes, it's Januvia. It's Januvia. Yes. Yeah, so the gliptins, there is that potential for heart failure. So you ask yourself, if a person is at risk of getting heart failure, then rather not use the Januvia and the Galvus. Rather go to something else, or rather not use the class as a whole and use something that is going to be safe to heart failure. Bullous pemphigoid and so forth. Now, the closing slides and the closing remarks, we are now left with gliclazide. So we've tried the SGLT2s, we've tried the GLP-1s, we've tried the DPP-4s, now gliclazide. It is an old molecule. We're adding now metformin with an old molecule that has been around forever. I mean, it's one of the first oral agents that was discovered even before metformin. So we can add gliclazide, and when you compare this gliclazide together with all the others, including DPP-4s as well as SGLT2s, what are the benefits? Greater A1C reductions. And that has been the message, the core of the message. You want something that's going to reduce the A1C dramatically and reduce it fast. So it may still be well to use the same old, especially if it doesn't attract a co-payment. And I'm not saying this because I'm paid. This is not because I'm paid, guys. Rates of hypoglycemia with gliclazide compared to DPP-4s, it's much the same, really. It's more or less the same because that is glibenclamide in pink and that is gliclazide in blue. And this is sitagliptin at 6.7, that is the light blue. And the rate of of a hypoglycemia it looks like it's comparable, if not better, with gliclazide, MR, the modified release being the operating word. I'm not going to go into that. Again, suffice it to say that it does show that the relative risk with gliclazide is similar to that of metformin, even metformin, than other SUs. And although the class is important, drugs with the same class may exhibit real and important differences in hypoglycemic risk. So it's not like one drug is the same as everything else. I'm going to jump this slide because it does not even reflect very well, but the weight gain that is expected to occur with sulfonylureas is not as dramatic as it is expected, to a point that it may be safe to say they can be weight neutral. Gliclazide has a low risk of hypoglycemia, which is similar to DPP-4s. It is weight neutral. And the question about safety, vascular cardiovascular safety with SUs, they are safe. Just that slide, it just says in summary, they are safe to use as for cardiovascular safety. So in summary, DPP-4s may have, they do not even have a superior durability compared to gliclazide. They have more or less the same durability in terms of pancreatic cell decline in the long term. So when we're asking ourselves, are the newer drugs superior to SUs, especially with gliclazide, MR, modified release? The only drug that we can say without a shadow of doubt that is superior to SUs when compared to the others in the classes, it is dulaglutide. Otherwise, all of them, they confer the same benefit when it comes to the additional drug to use in the 85% of our patients who do not have cardiovascular conditions or complications. So in summary, what I'm saying here is that when you're looking at all these drugs that we are using, you have a patient who has got complications, already established complications. You have a patient who does not have complications. You are faced with adding a second drug to metformin. Which option are you going to use? You must choose that drug that you're going to use based on the treatment side effects, on the patient's framework as to exactly what may benefit him, what is reliable for the patient, and what can the patient practically afford. And you use that as a decision factor for what you want to use. In summary, I'm going to jump most of this because of the love letter that's sitting in front of me. In summary, when you're looking at gliclazide, it is a trustworthy drug. It can be added safely. It can be added to metformin for patients who are free of the cardiovascular risks. It can be added before the others and then together with metformin. If you want to use triple therapy, you can consider the newer drugs. So having said that, if a person can benefit from other drugs as well, look at your patient's benefits, look at the patient's profile and decide what other drugs you can use. But what is lovely about this is that even an old molecule is still as relevant today as it was back then. I mean, metformin is still as relevant today, and sulfonylureas remain relevant. Insulin remains relevant, even though we have got the newer classes, the GLP-1s, the SGLT2s, and so forth. So glycemic durability is still equivalent with the gliclazide compared to the newer molecules, and renal protection becomes a consideration, especially because when you're looking at the drugs that we can use in the long term, we know that our patients will eventually become, some of them may suffer from kidney disease. So what do you use in patients who have got diabetes and end-stage kidney disease? You're limited there for options. DPP-4s are the ones that go all the way without having to have any adjustment to the doses. Gliclazide you can use up to about 30%, that is stage 3. The others they're very limited in use. The gliptins you can use all the way, but then you can reduce the doses. So the DPP-4s are the ones that you can use all the way, even though they may have advanced chronic kidney disease. There we go. So in summary, there is a rising burden of diabetes, sedentary lifestyle, stressful lifestyle, medications, COVID, and so forth. Patients need to be treated early and aggressively, especially to make sure that we don't end up with the burden of sitting with untreated conditions. Thank you very much.